consultant, clinical oncology, and she's going to give us a presentation about chemotherapy in breast cancer.
Bismillah ar-Rahman ar-Rahim. In the few coming minutes, I'm going to present what's meant by cancer, types of breast cancer, what's chemotherapy, which patients receive it, side effects, targeted therapy, and chemopreventive therapies. What's meant by cancer? The word cancer refers to changes in the body cells that allow these cells to grow out of control. These cells often grow very fast, crowding out normal cells. Cancer cells also have the ability to spread or metastasize to other organs in the body. The DNA controls all cell function, including when to divide and when to die, a process named by apoptosis. Malignancy transformation begins when the DNA becomes damaged. When DNA is damaged, some cells become unstable, dividing more than normal cells or fail to die. Most of the time, the body's immune system finds these damaged cells and destroy them. However, if this normal process does not happen, a tumor begins. A tumor may be a benign tumor or malignant tumor. A benign tumor do not invade and do not travel to other parts of the body. And the malignant tumor invade and can travel to other parts of the body. Now, there are different types of cancer breast. The carcinoma is the most common type. The adenocarcinoma, sarcoma, phalloid type, inflammatory breast cancer are rare types. Now, what's meant by chemotherapy? Chemotherapy is a cytotoxic medication that prevents cancer cells from dividing and growing. There are 5 goals for the chemotherapy. Either to let the patient enter in total remission, that means increase overall survival, that means to cure the patient completely in some cases, or to increase disease-free survival, that means to prevent the return of a cancer, or increase time for disease to progress, that means to slow down cancer progression, used mainly when the cancer is in its advanced stage and a cure is unlikely, or combination therapy with either radiation therapy or surgery, to have the more effective results, or palliative. Now, how does the chemotherapy work? This is the normal cell cycle that almost of us know it. First of all, it works by impairing mitosis, that means prevent cell division. That's why they are known as cytotoxic agents. There are different types of cytotoxic agents, like the alkylating agents, as the cyclophosphamide and cisplatinum. They target the DNA synthesis, or anti-metabolite agent as the 5-FU, Xeloda, gemcitabine, and methotrexate that interfere with the building block of the DNA synthesis, or has an anti-tumor antibiotic agent as the doxorubicin or the adriamycin or anthracycline or epiropsin. They prevent the DNA replication and the messenger RNA production, or mitotic spindle agents as the taxanes or the nevilpine, by inhibiting the mitotic phase of the cell cycle. The second way is the targeting cancer cells' food source as the receptors or the hormones they require in order to grow, as the monoclonal antibody, anti-human epidermal growth factor receptor, the HER2/neu, as the trastuzumab drug or the Herceptin. These cancers with overexpression of the HER2/neu positive 3 tend to grow and spread more aggressively than those with negative HER2, or the tyrosine kinase inhibitor as the lapatinib, going to be discussed later. Estrogen receptor and progesterone receptor. Normal breast cancer and some breast cancer cells contain receptors that attach to the estrogen and progesterone. These 2 hormones often fuel the growth of the breast cancer. Hormone receptor positive breast cancer tend to grow more slowly and are much more likely to respond to hormonal therapy than breast cancer without these receptors. All of us know the staging breast cancer system according to the American Joint Committee. The tumor size, first of all, the TIS, the carcinoma in situ, T1 is less than 2 centimeter, T2 is 2 to 5, T3 is more than 5 centimeter to 4, growing into the chest wall, or inflammatory breast cancer. For N1, it is 1 to 3 axillary lymph node, N2, 4 to 9, N3, more than 10, or involvement of the supraclavicular lymph node. The 5-year survival, according to the stage, in the non-invasive type, the ductal carcinoma in situ and the lobular, it's 93. And for the invasive type, it's 88 to 49. And in the metastatic cases, it's 15%. There are a different strategy in treatment of breast cancer, starting from surgery, radiation therapy, chemotherapy, hormonal therapy, and targeted therapy, or a combination of them all. For the carcinoma in situ, the lobular carcinoma in situ and the ductal carcinoma in situ both require surgical treatment with or without radiation and endocrine therapy if the estrogen receptor was positive. Chemotherapy is not necessary. For the invasive cancer breast, there are 2 ways, either adjuvant therapy or neoadjuvant chemotherapy. Adjuvant and the neoadjuvant therapy reduces the mortality at 10 years by 20 to 38% and reduce the recurrence rate by 30 to 70%. Now, what's the indication of preoperative chemotherapy or the neoadjuvant chemotherapy? For stage 2A and B, and for stage 3A and B. And what's the importance or the advantage of neoadjuvant chemotherapy? First of all, is achievement of pathological complete response shows improvement in disease-free and overall survival compared with patients with residual tumor at the time of surgery. Second is conversion from modified radical mastectomy to breast conservative surgery in some cases. And the third is a predictor of tumor response to treatment. Now, when to give post-operative chemotherapy? In patients having positive lymph nodes or patients with hormonal negative receptor, patients having HER2 new overexpression in positive 3 or high grade or high Ki-67 or high oncotype DX, going to be discussed later. These are some of the most commonly used drug combinations, CMF, AC regimen, AC regimen. I think some of you knows about it. Now, which type the patient receive will depend on the prognostic risk types. There are different prognostic factors used in the daily clinical practice. Some of them are patient-related factors, the others are disease-related, and the others are biological biomarkers, the estrogen progesterone expression, the HER2 expression, and the proliferation markers Ki-67 and oncotype DX. Now, what's the Ki-67 and onco-DX? The Ki-67, it is the rate of cancer cell division. The S phase is the percentage of cells in a sample that are replicating their DNA. If the S phase fraction or the Ki-67 labeling index is high, it means that the cancer cells are dividing more rapidly, which indicates a more aggressive cancer and needs more aggressive chemotherapy. For the oncotype, it's a gene expression profiling that help to predict whether or not an early breast cancer is likely to recur after, so decide whether additional adjuvant or post-operative chemotherapy might be useful. That means patients with a low recurrence score may be able only to receive hormonal therapy and avoid chemotherapy. In Sagal and consensus for breast cancer, they divided the breast cancer into risks, low risk and intermediate and high risk. Low risk patients, usually we give them endocrine therapy only and avoid as much as possible the chemotherapy. Low risk are those patients with high estrogen and progesterone level, grade 1, low proliferation index, node negative, absence of extensive pretumoral vascular invasion, tumor size less than 2 centimeters, and HER2 is negative. And the intermediate and low and high risk, are those with lower estrogen progesterone level, grade 2 to 3, proliferation index intermediate or high, positive lymph nodes, presence of extensive pre-tumoral vascular invasion, tumor size 225, and HER2 positive. These patients need taxanes to start. Addition of taxanes to the chemotherapy increases the disease-free survival to 28% and overall survival to 30%. Sequential taxanes after anthracycline-based is less toxic than combined. Anti-HER2 or the Herceptin or trastuzumab must be added when the HER2 score is 3. The earlier, the better, because it improved also the disease-free survival by 52% and overall survival by 33%. So in intermediate and high risk, or better in high risk patients, AC regimen, 4 cycles, AC means anthracycline-based and indoxan, cyclophosphamide, 4 cycles followed by taxanes, 4 cycles with or without Herceptin for 1 year is the treatment. Anti-estrogen hormonal therapy in hormonal positive patient is given after chemotherapy by 1 month. In metastatic case, 4 to 6 patients of breast cancer are metastatic at diagnosis. Of those, approximately 1/5 will survive 5 years. The prevalence of metastatic disease is high because many women live with the disease for several years. Depending on prognostic factors, in the worst case scenario, up to 30% of node negative and up to 70% of node positive breast cancer will relapse. Factors to consider in risk assessment and treatment decision making for metastatic breast cancer, there are 2 different factors related to the disease and related to the patient. In metastatic and relapsed cancer breast, a multidisciplinary team must be gathered, formed of surgeon, radiologist, radiotherapist, oncologist, and palliative care. For metastatic patients with breast cancer, hormonal positive, endocrine therapy is the preferred option, except if clinically aggressive disease mandating a quicker response, or if there are doubts regarding the endocrine responsiveness of the tumor. Cases with HER2 overexpression, addition of anti-HER2 therapies to the hormone treatment is beneficial. Patients with triple negative, that means hormone negative and HER2 non-overexpressed, they are candidate for cytotoxic chemotherapy. The only standard of care with the level 1 evidence is the use of taxanes-based regimen as first-line therapy in patients progressing after adjuvant anthracycline-based chemotherapy. But if patient received it previously and relapsed or metastasized in a duration less than 12 months, then second line must be given composed of gemcitabine, nevirapine, Xeloda, with or without cisplatin. Single agent chemotherapy is equivalent to combined therapy in overall survival in asymptomatic patient only given. For symptomatic, it's preferred to give combined therapy. Chemotherapy drugs work by attacking cells that are dividing quickly, which is why they work against cancer cells. But other cells in the body, like those in the bone marrow, the lining of the mouth and intestine, the hair follicle, also divide quickly. These cells also likely to be affected by the chemotherapy, which can lead to the side effect in the form of hair loss, mouth sores, loss of appetite, nausea, vomiting, low blood cell count. There are also specific side effects according to the drug. Cardiotoxicity and cardiomyopathy in anthracycline and Herceptin taxanes, that's why we usually do for them echo before chemotherapy and as a follow-up after. Impaired deafness, in some cases using the cisplatin, nails and skin changes, hand and foot syndrome for patients using the 5-FU Xeloda, neurotoxicity in taxanes, that's why sometimes we give a prophylactic vitamin D, osteonecrosis of the jaw or hypocalcemia in bisphosphonate patient receiving. Now please, keep your smile and hope, as there are the targeted therapy and chemopreventive. As researchers have learned more about the gene changes in cells that cause cancer, they have been able to develop newer drugs that specifically target these changes. These targeted drugs were differently from standard chemotherapy. They often have different or less severe side effects. They are most often used along with chemotherapy and as maintenance drug in metastatic case. Some of these targeted drugs as the trastuzumab, the Herceptin, discussed previously, and the lapatinib. This drug is given as a pill to women with advanced HER2-positive breast cancer that is no longer responding to chemotherapy and trastuzumab. And the coming new drug, the everolimus, Afinitor, mTOR inhibitor, is anti-mammalian target, anti-angiogenic and anti-proliferative, used in postmenopausal women with hormone receptor positive, HER2 negative breast cancer that has stopped responding to letrozole or anastrozole aromatase inhibitors. The chemo prevention is the use of the drug to reduce the risk of developing breast cancer. Tamoxifen and raloxifene block some of the effects of estrogen on breast tissue. Women taking tamoxifen had 42% fewer breast cancer than women who did not receive. Keep in your mind, prevention is better than cure. Early detection prevents the hazards of aggressive treatment. Targeting cancer cells, food source, receptors, or hormones is the new era to indicate which patient will receive which drug. Thank you.
Thank you very much, Dr. Rabab. I think we will keep the questions at the end of the session. And if Dr. Said is 1 minute, Dr. Rabab. Yeah, because I'm sorry, because Dr. Said is not yet arrived, so we'll take some questions for any question regarding the chemotherapy and breast cancer.
I tried to make it clarified and simple so that everyone can understand. I know chemotherapy is very complicated, and the era of chemotherapy and the protocols of chemotherapy, many of us are disturbed from it, and many of even the doctors, they are afraid of chemotherapy. But now, as I said, in the new era, we can decide which patient to receive which drug. We are more targeting the cancer cells.
About the patient taking a treatment of chemotherapy, and what they should observe side effects. For example, I noticed in one of the slides that Zumeta can lead to necrosis in the jaw and problems with the teeth. So if they know these side effects in particular, so they know when to refer the patient to the proper treatment. But what's the message that you want to convey to the primary healthcare physician in this regard?
As I said in the last slide, prevention is better than cure in even giving the chemotherapy. That's why with chemotherapy we are giving prophylactic treatment for everything, because we know the side effect of the drug. So we are giving the prophylactic to develop the side effects, so that the patient, as much as possible, live a comfortable life without side effects. Like the bisphosphonates, having hypocalcemia, we keep the patient under prophylactic calcium and vitamin D supplement, and we can increase or decrease the dose according to monthly reported calcium level, ionized calcium level, not total calcium, the ionized level. This is for the bisphosphonates. And for the other drugs, as anthracycline or the Herceptin or taxanes that are having cardiac toxicity, we usually use the echocardiography to assess the ejection fraction of the patient on each 3 months to detect whether to continue the same treatment or just stop prior happening any appearance of the side effects.
If you allow me, Dr. Rabab, to go back to your question about the osteonecrosis and what the primary healthcare physician should know. The most important piece of information they should know that this incidence of osteonecrosis is really rare, very rare. It's less than 2%.
2%.
I'll give you an example. I have been practicing oncology for the last 25 years, and I haven't seen a single case of osteonecrosis as a sequence of the use of bisphosphonates. And we have to encourage patients to use bisphosphonates because nowadays it is very rare to find a patient with hypercalcemia because of the wide use of bisphosphonates to control pain. So the most important message is to convey the message that this is a very rare side effect of bisphosphonates. However, we should live in the common but do not forget the rare. If the patient has persistent pain in the jaw, Or if the patient under bisphosphonates is going to have any surgical procedure, tooth extraction or anything like that, we have to inform the dentist about that the patient is taking bisphosphonates, and the dentist must guard and take the precautions with proper antibiotics, and to keep notice if the patient has persistent pain and there is nothing appeared in the tooth problem or anything, in that case, this case should be investigated. So the communication between the oncologist and the dentist and the primary care physician is paramount. And thank you for this question because it's really important. So
the other passage now, chemotherapy is not like before. It's the big devil that the patients usually they are scared from. And now even in Europe, patients who is under chemotherapy, they are followed by their primary care. So primary care physicians should also be aware from the other side effects of like low white blood cells, whatever, low platelets, so anything related to low counts. If they have fever, whatever they have, they should be aware how to manage such a patient and when to refer those patients to the specialized hospital. They should know what is their limitation in management and when to refer. I think this is a very like a small red line when to refer.
Actually, this is an excellent question. I'm sure Dr. Rabah will answer that.
Actually, I think it's a comment, right? You think a comment?
I mean, and this is where this is our role in our campaign. Instead of telling them about the chemicals, the compounds, because this is not their specialty. They don't care about it. They care about the complication when they receive, when to refer.
I tell you something. The first time the patient receives chemotherapy is the most important time to both the doctor and the patient. So patient must be aware of his disease and must be aware of side effects that may appear with the chemotherapy. These side effects I introduced with some drugs. These are rare side effects. We usually don't see them because we are preventing them to appear. But we have to.
About the patient when he is discharged at home, and then he's sitting at home, if he has fever, for example, and he's going to the neighboring primary care physician, that primary care physician, what is the basic information he should know about the chemotherapy side effects? What is the minimum information he should know about chemotherapy side effects, blood tests, and when he should refer him to you or keep him with him?
No, I tell you something. Usually the neutropenia develops after 1 week to 10 days of chemotherapy. That's why we have to inform the patient, please, within the first few days, take care not to be combined with any infected person or patient, or anyone having cough or fever, because you will have a low count. So you will be able to have this infection rapidly. We inform also the patient if he develops fever at any time, high-grade fever, he has to inform us or to come to our emergency so that we can do for him a CBC to detect the total leukocytic count if it is below 1 or more than 1, because if it is below 1, it is mandatory that the patient must be admitted in the hospital and isolated. But more than 1 total leukocytic count, the patient can be discharged to his home with antibiotic and antipyretic, okay, and repeat the CBC after 1 week.
You are absolutely right, Dr. Rabah, and if you allow me to, because your comment is really valid and it's very important. Again, we have to explain to the patient that not every patient is going to receive chemotherapy might have febrile neutropenia. It does depend on the type of chemotherapy the patient is going to receive. Some chemotherapy regimen will not touch the immune system and it will not cause neutropenia. Others, the incidence of febrile neutropenia might reach 40 to 60%. So the key message to the primary health care physician, not every patient receiving chemotherapy and they develop fever is going to develop febrile neutropenia. The key factor is the blood count. As long as the neutrophils more than 1.5, the patient is safe. This is number one. However, sometimes the patient will not present with fever, but there are other alarming symptoms and signs. The physician should receive the patient to the tertiary care hospital, like if the patient is feeling not well, if the patient is shivering, if the patient hypotensive. Even if there is no fever, this is alarming signs. And even if the leukocytic count is normal, because it might be normal now, but if you repeat it again after 1 or 2 days, it will be low. The most important thing is the clinical assessment and the clinical judgment. If the patient is saying, I am not well, I feel shivering, blood pressure is low, all these cases, if we combine that and the patient is receiving chemotherapy, patient should be referred to tertiary care hospitals. This is number one. Number two, as Dr. Rabab correctly said, that the febrile neutropenia usually between 1 week or 10 days, and this is for most of chemotherapy regimens. However, for chemotherapy containing taxanes, febrile neutropenia might happen within the first 3 days. But as Dr. Rabab mentioned, most of the chemotherapy, the neutropenia will be between 7 days and 10 days. However, with taxanes, neutropenia could happen in the first 5 days. So this is a very good comment, and the primary health care physician should be aware of the alarming signs of febrile neutropenia. Any other questions?
Yes, I want to ask. All patients with diabetes and hypertension are receiving chemotherapy. Whether there is any interaction with oral hypoglycemic?
No, there is no interaction in the, as I know. No interaction between either the insulin or the oral hypoglycemic drugs with the chemotherapy, and even the antihypertensive. But what we can keep in mind in taxanes, especially the patients receiving the Taxotere regimen, we give them corticosteroids pre-chemotherapy and post-chemotherapy. That means they are going to receive high doses of steroids that will elevate more the blood sugar and the hypertension. So these patients must be kept in close follow-up, and we have to give instructions to the patient. Then you have to measure your blood sugar before taking the steroids, pre and post chemotherapy, so that any elevation of the blood sugar can be treated immediately. Also, all patients with chemotherapy, receiving chemotherapy, we are giving them prophylactic treatment at home with instruction of what food to receive within the first few days, so that patient stays in the first 1 week, because the first 1 week is the most important week after chemotherapy, because the patient feel like he's in like he's sick a little bit, with he may develop easily fatigability, dizziness. That's why we give him some information. Please, in the few days, don't have a fatty diet. Don't try to take something like orange or lemon juice, as not to increase the gastritis in the abdomen. This is also in addition with the prophylactic drugs like the omeprazole or the Losec, with something like anti-emetic drugs, so that the patient will not develop any type of side effects and to live his life normally.
Any other questions?
Thank you very much, Dr. Oh, very interesting presentation.
Thank you.
I have two questions or comments. One is about the indications for new adjuvant chemotherapy.
Yes.
I was surprised that you mentioned stage 2A
This is the
case for the new adjuvant therapy, because usually I understand for stage 3, but stage 2A means that the patient has a small tumor with some lymph node metastasis.
Unfortunately,
we do the breast surgery, the lymph node dissection, and we give them adjuvant chemotherapy, not necessarily new adjuvant.
yes, you are right. In our daily practice, it is right, but unfortunately, this is the NCCN guidelines 2013 and the ESMO guidelines That's why I wrote it down, because I know this comment will appear, because usually in practice we do not do this.
Okay. The other question is about the indications for chemotherapy generally.
Yes.
You mentioned, for example, HER2, you mentioned
overexpression.
Overexpression, you mentioned negative receptors, because these are all bad signs. So these are indications for chemotherapy. But I think you didn't mention the size, because if the patient even doesn't have all of these, if the
size of the tumor,
then I would give chemotherapy.
Do you mean the size of the tumor?
Yes.
It's written in the Sangallen. I discussed it in Sangallen, the intermediate and high risk. Those patients above 2 centimeters. Yes. It's
Any other question? Thank you very much, Dr. Robert.
Thank you.
Interesting.